In this video, we are going to see about automated vitrectomy. Settings for automated vitrectomy. The three settings are very important. First is cut rate. It is maximum for the machine. For Lorette, 1500 cuts per minute. For Centurion, 4000 cuts per minute. Second is flow rate, which is 20 to 25. And the third is vacuum, which is 250 mmHg. There are two modes in vitrectomy. First is cut IA, where the phaco foot pedal position 1 for irrigation, position 2 for vitrector, and position 3 for aspiration. And the second mode is IA cut, where the phaco foot pedal position 1 used for irrigation, and position 2 used for aspiration, and position 3 used for vitrector. Role of circulating nurse. Should check color change in the indicator and ETO packing. Should check the reusable sticker behind the vitrectomy probe ETO pack. Should use hand rub before opening the packs. Should retain the ETO pack with reusable sticker and hand it over with the used probe inside for cleaning and sterilization. The vitrectomy probe after usage should not be placed anywhere carelessly. Role of surgeon. Make sure that everything is done in a sterile manner by the circulating and assisting nurse. Check and reconfirm the settings and the bottle height before the procedure. Ensure that the used probe is properly handed over for cleaning. Role of assisting nurse. Check for color change of indicators and ETO pack. Proper attachment of handpiece or tubings in the correct sockets of the phaco machine in a sterile manner. Check for vacuum, movement of blade in the cutter and the bottle height. Check for proper machine settings for vitrectomy and confirm with the surgeon before starting the procedure. Immediately after the procedure, the probe should undergo aspiration and drying attached to the machine. Should make sure that the running sister replaces the probe in the appropriate pack for cleaning. How to handle the complex cases. General precautions in block room. Senior MLOP in the block room has to take complete responsibility for the patient. Triaging of complex cases needs to be done and the patient is allotted to the surgeon with appropriate experience. Specialty clearance for the particular case needs to be ensured. Special advice, if any, has to be noted and ensure that they are followed. Make sure that the guarded visual prognosis form is completed and the patient is aware of it. Decision on monitoring on table, type of block, and the mode and the time of shifting the patient should be decided in consultation with the operating surgeon. General precautions in the operating room. On table requirements like automated vitrectomy, orogel or biscote, iris or capsule loops, CTR or CTS, special IOL requirements, special instruments needs to be ensured before starting the surgery. After surgery, the proper postoperative notes has to be entered in EMR real time by the blockroom doctor. Postoperative ward. Monitoring of these cases in the immediate postoperative care in the OT has to be done. Proper handling over of the patient to the ward MLOP has to be done to ensure that the instructions from the operating surgeon and the OT physician are followed in the ward. Decision on admission has to be taken if it is a daycare case. Any extra charges or concession has to be immediately taken care of. Triaging of complex cases. For mild risk cases include dilated mature or brown cataract, small pupil with NS1 to NS3 cataract and deep socket. Moderate risk cases include posterior polar cataract, small pupil with mature or brown cataract, phacolytic glaucoma, hazy cornea, traumatic cataract, high myopia, apprehensive patient, seropositive or HBsAg positive patients, one-eyed cases without risk factors, and pseudo exfoliation, which includes moderate to high risk. High-risk cases includes VIP patients, IV sedation, coloboma with cataract, head nodding, and abnormal postures while lying down, phacomorphic glaucoma, microcornea or nanophthalmus with cataract, one-eyed patient with risk factors, traumatic cataract with corneal scarring or dialysis or vitreous AC, post-LASIK, PKP, TRAP or retina surgery, and subluxated cataract. High myope with cataract. Check whether the appropriate IOL is available in the substore. Abnormal powers like less than plus 17 diopters to minus 10 diopters and more than plus 25 diopters needs to be double confirmed by the circulating nurse with the OT in charge nurse along with the patient case sheet and IOL master sheet. Ensure the number of IOL is available in that particular power in the store. This is necessary if the IOL becomes unsterile or breakage during loading. If only one IOL is available, note the power of the next available IOL. Only the subtenon's block should be given either in the block room or on table. Surgeon needs to be informed and a senior assisting sister should be asked to handle the IOL. In case of any intraoperative change in the IOL power, the double confirmation has to be repeated. Phacolytic glaucoma. This patient should be handled by senior MLOP in the block room. Ensure that the patient has been seen in glaucoma clinic and has got clearance for surgery. Ensure guarded prognosis form has been signed by the doctor and the patient. Ensure patient systemic status before giving oral glycerol or IV mannitol. And it should not be given in cases of pulmonary edema, progressive heart failure, renal disease, severe dehydration. An IV mannitol should be given 30 minutes before surgery. Surgeon should be informed before block and patient should be asked to drain his bladder before giving IV mannitol. Patient who has been administered IV mannitol should be only shifted by stretcher. Assisting MLOP should be prepared with high-risk hook, automated vitrectomy, CTR and 3-piece IOL. Phacomorphic glaucoma. All precautions are same as phacolytic glaucoma case. Ensure guarded prognosis form has been signed both by patient and advising doctor. Additionally, vitreous tap needs to be taken on table in view of very shallow AC. Retina fellow or medical officer needs to be informed and the procedure needs to be done carefully. Eye sense of alert has to be ensured in the operating room as chances of expulsive hemorrhage is high. Posterior polar cataract patient. Ensure that the pupil is well dilated. Check whether the guarded prognosis form is completed and the patient is aware of it. Ensure that a 3-piece IOL is available for the particular power. Block the patient according to the surgeon preference. Inform the surgeon about the case and plan accordingly. Assisting sister should be alert and be prepared for posterior capsule dehiscence or conversion from phaco to SICS. In case of PC rupture, ensure that the 3-piece IOL is of appropriate power and to be rechecked by assisting sister and surgeon. In case of nucleus drop, the remaining cortex needs to be removed after automated vitrectomy and wound sutured after placing a 3-piece IOL in the sulcus. It will be preferable to do optic capture of the IOL. The patient can be shifted to retina OT in consultation with the retina team and this has to be coordinated by the OT in charge. Correct and complete OT notes to be entered from both the OTs. Extra medication needs to be noted and ensured that they are dispensed. Patient has to be admitted. Extra charges or concession needs to be addressed by the operating surgeon. Breaking the news to the attenders after completing the OT section, post-operative care and the follow-up will be the full responsibility of the operating surgeon. Things needed for complex cases. Automated vitrectomy probe, high-risk hooks, capsule hooks, Hookland hooks or spatula, CTR, Prolene suture with staked needles, iris claw lens, injection pylomin, and injection tricot diluted. How to handle the complications? On-table precautions. No unnecessary talk between the doctor and the sister or between the sisters following a complication. Every team member in the operating room needs to be communicated and aware about the occurrence of a complication so that they start preparing for it. Calmness to be followed with quick assessment regarding the nature of the complication and the competence of the surgeon to handle it or call for appropriate help. The assisting sister can also help the surgeon in taking that decision. Senior surgeon can be called for help in cases of dialysis of back or iris, and corneal surgeon can be called for DMD, and in cases of any cortex or nucleus drop, retina surgeon and the team can be called for help. Necessary things to be arranged for further dealing with the complication in a shift manner. One of the circulating nurse needs to be present in the operating room always to coordinate. Simultaneously, the OT in charge MLOP or a senior blockroom sister needs to be informed regarding the complication so that they can plan the next case for the surgeon and also visit the operating room to see if they require any help and also to ensure that no error happens. The aim of managing complication will be to give the best possible outcome in the shortest time possible. Complete cortex removal, vitreous-free anterior chamber, and proper wound closure has to be ensured. The need for final inspection by a senior surgeon will be decided by the operating surgeon or in charge sister. It is very important that the surgeon informs the patient inside the operating room regarding any change in type of implant or sutures. Accurate and relevant post-op notes have to be entered. Vivid notes has to be avoided in the EMR. Post-operative precautions. Extra medication prescription to be handled down to the patient and ensure that they are administered on time. Need for admission confirmed. Extra charges or concession needs to be addressed. Explaining the significant complication to the attender immediately is very important. The OT in charge sister should first meet the attender and give an initial update and tell that the operating surgeon will come and talk as soon as they finish the section. The operating surgeon will also go and explain what is necessary to the attender and the patient. Can also take the help of the senior doctors if required. Next day, patient condition needs to be seen and followed up by the operating surgeon and the assisting sister. Antibiotic protocol for intraop complication. Intraoperative. Intracameral injection moxifloxacin has to be ensured. Post-operative, tablet ciprofloxacin 500 mg BD for 3 days or tablet ofloxacin, tablet pantoprazole, NSAID drops like Nepalact, eye drops to be added. Second hourly topical antibiotic after opening the bandage on the same day and the next day till morning post-op rounds. Contraindications: no tablets or IV or IM dexamethasone before postoperative rounds. Thank you.